Hi, my name is Monty Pal, and I'm a medical oncologist at City of Hope in Los Angeles. Welcome to GU Oncology Now.
I'm Brian Rini. I'm a Chief of Clinical Trials at Vanderbilt University Medical Center, and we're going to talk today about several different areas of kidney cancer. We're going to start with a debate around frontline treatment and an individualized approach versus a one-size-fits-all approach. And then we'll go into some other topics, including clinical trials and adjuvant therapy. So I'm going to open by talking about frontline therapy in kidney cancer. As everybody knows, there are 4 immune-based doublets that are standard of care that have all shown improved survival, Ipi-Nivo, and then the 3 IO-TKI doublets. And I would argue that each of them has unique strengths and weaknesses. If you look at the IO-TKI regimens, they have quite obviously different TKIs. There's different dosing strategies. Lenvatinib at a very high dose, Cabo at a somewhat middle dose of 40 milligrams, and axitinib at a middle dose of 5 milligrams BID with titration. So I think in terms of the TKI part of that, using those regimens allows you to differentially dose the TKI. For instance, I tend to use Len-Pembro, but understand that 20 milligrams of lenvatinib is a lot for patients, so tend to use Axi-Pembro in a more frail population. Ipi-Nivo has its strengths, right? The tail of the curve, I think, is probably a strength. And certainly in sarcomatoid, right? There's really good data for sarcomatoid histology being a nice biomarker for Ipi-Nivo response with CR rates that were almost 25% in that analysis of 214. So I think there are differences among the regimens, and I think there is some role for individualizing therapy.
It's a really interesting take on it, Brian. I often think of the practical circumstance that patients in the community face. Most oncologists are seeing maybe 2 to 3 patients with kidney cancer a year, and looking to some of the nuances of the data, I think, is a little bit challenging. I've heard folks say, well, I'll go with lenvatinib and pembrolizumab if I want to sort of get a higher response rate, and I'll go with Nivo-Ipi if I feel like I have more time with the patient. I can think of very few instances, except those cases where you've got lots of chronologic scans where you can really predict the tempo of the disease. I find that to be quite challenging. And, when I think about the response rate argument, for instance, for Len-Pembro, I often think about the differences in the demography in that study. More patients with good risk disease, for instance, fewer patients who had cytoreductive nephrectomy compared to, say, regimens like Cabo-Nivo. So I tend to be a little bit more dogmatic. I tend to start most of my patients on Cabo-Nivo up front, use the general arguments of the response rate being on par with other TKI IO regimens, reasonable tolerability, and that quality of life data that seems to stick out a little bit to me amongst the other TKI IO regimens.
Yeah, I think your point about limited number of kidney cancer patients is a good one. I will say, if we look at other malignancies, there's plenty of other malignancies where there's regimens to choose from, and oncologists may use different regimens for different circumstances. And since I don't see those other malignancies, I can't really cite examples. But I don't think we should underestimate a community oncologist's ability to differentiate among the regimens. And I don't think it has to be super complex, right? If they're sarcomatoid and can tolerate Ipi-Nivo, then that's a good regimen. Right? If they're not, or if you're using an IO-TKI and you think they can tolerate a higher lenva dose, then I think those data are more robust, notwithstanding comparisons across trials. So I will agree that understanding a given regimen and being able to give it thoughtfully in terms of dosing of TKI and when to hold is important as well. Obviously you have to be able to deliver the therapy to deliver the benefits.
I think you highlighted there are 2 important circumstances, or it's certainly one where, it's a given that the patient should have some consideration of Nivo-Ipi, and that's in the patient with sarcomatoid disease, especially those, dominant sarcomatoid tumors. I think those are ones where Nivo-Ipi is a must. I can also think of patients who, for instance, really need to head to the OR, for instance, right away for cytoreductive nephrectomy. And in cases like at my institution, sometimes you're waiting 4 to 6 weeks to get that surgery done. Nivo-Ipi is a great place to start, just so that patient's on a systemic regimen and can get bridged through surgery without having the complications around TKI. Sometimes I'll vote in favor of that. But other than that, I think that, our good friend Tom sort of always makes this point that there's more similarities than differences amongst many of these regimens that we have for advanced renal cell carcinoma. And I think that it's just a difference in philosophy, I think, rather than sort of looking at the individual patient in front of you and thinking, how does this large data set apply? I think that it's that juxtaposition of the large data sets against one another that I'm probably leaning on a little bit more.
Yeah, I think that's fair. So good summary of the frontline nuances and differences in approach.